Good morning, everyone. Welcome to the conference, and thank you very much for being willing to listen to this pre-recorded presentation. I'll entitle it A Call to Action for Cardiologists, Impactful Artificial Intelligence, Leading to Data-Driven Clinical Decision Support and Value-Based Care. Really our future, and I think that it isn't so surprising to you that I would appeal to cardiologists as some of the key drivers of advances in healthcare and, frankly, healthcare economics to participate in this effort that will pervade all of our healthcare delivery systems. I have no disclosures related to this particular presentation. This slide is meant to show you the scale of Mount Sinai Health System. Well, Mount Sinai Health System is only one example. Chances are that many of you are working in a context where, if you're not a direct employee, you interact with the health system. And I think it's so important that you realize that this is not something which is going to go away. In fact, the trend is very well established. Showing you on this slide the bond rating distribution of health systems versus standalone medical centers. Yes, this is a snapshot from 9 years ago, but it proved the point, and the point really has not changed since then, that health systems have better economics than standalone hospitals. And so this has become, in many ways, the way of the world in the United States, which is that the consolidation of healthcare into the large health systems is something that is here to stay. As we go on with this talk, I want to just give a little bit of a caveat, a little bit of warning in terms of what are true drivers of cost and what are perhaps false. Let's start with the false. I will often have people come to me and say, well, the annual budget for the operating room is this number, and the number of minutes of OR time we have over the course of a year is this number. We could do the same thing for a cath lab, let's say. So they will then say to me, well, it's X number of dollars per minute of OR time, cath lab time, PACU time, and ICU day. And they do this just with that simple division. You might say the same thing for looking at the cost of an MRI if you were to take the same approach, or any sort of high cost effort that we make in the hospital. But this is really false. What is true is the cost of the nurses, the anesthesiologists, the technicians that support the cath lab, the surgeons and cardiologists, the support staff that actually make these encounters occur. And further, the cost of purchasing, maintaining, and staffing a cath lab, an MRI. So these are true drivers. If you come up with a process that's more efficient and we need fewer people, or we need less in the way of supplies, then we will be successful in moving the needle on that value equation. So again, the economic drivers of healthcare are personnel. FTE stands for full-time equivalent. So that would be doctors, nurses, the advanced practice provider extenders that we talk about, physicians' assistants, nurse practitioners, and all the support staff. So what's really expensive in healthcare? Well, hospital care, critical care, cath lab care, emergency departments, post-acute care, in skilled nursing facilities, long-term acute care hospitals, home care provided, supplies, the drugs and the remainder of the supply chain. And I would add especially, and I'll come back to this in cardiology, the cost of catheters and rhythm management devices. And then finally, the capital cost of an aging infrastructure. Almost all health systems suffer from the need to continually upgrade their equipment in the various, in this case, we'll say catheterization or other cardiology procedural areas such as electrophysiology suites. Value metrics are very important for us to consider. So, for example, observed to expected mortality, complication rates better than benchmarks. And these are so important because not only do they control our reimbursement, our penalty avoidance, but also influence our rating by external organizations like U.S. News and World Report and Newsweek that rank our hospitals based upon these objective criteria. And beyond the external measures, we have to focus on infectious complications, observed to expected length of stay, and as cardiologists, especially on readmissions, in developing the teams that do their best to prevent readmissions, and visits to the emergency department that are otherwise avoidable. So your leadership as physicians on the teams that focus on readmission and length of stay are very important. And controlling costs within the healthcare environment. If we diminish the number of days people spend in a critical care unit or just in a regular hospital bed, that is very helpful. Reducing blood transfusions, utilization of laboratory resources, radiology resources, unnecessary consultations, and post-acute care, limiting an admission to a subacute rehab when in fact that care could be given at home. These are all very important. If you remember nothing else from this talk, please remember this slide. And just the simplified version is value equals quality divided by cost. If we had infinite dollars, we could have infinite quality in theory. But if you take the fact that we only will have limited resources that we can apply for quality, safety, and also patient experience or satisfaction, we have to consider what the cost of that will be. That is our value equation. And I would argue that is the best way for us to think moving forward. A national transition to value-based reimbursement has already occurred in the US pre-pandemic. You can see that what was originally just sort of pure fee-for-service has now evolved into payments linked to alternative payment models or fee-for-service linked to quality, more so in the blue. Because all of us have those sorts of reports. And so this isn't just Medicare. Our commercial payers in the US also have program risk calculators. And we could consider it penalty avoidance, or we consider revenue enhancement. I guess it depends whether you're a glass half empty or glass half full kind of physician. But the key thing to remember here is that everybody these days is monitoring our quality. And so whether it's a door to balloon time or it's an observed to expected mortality in a cath lab, these things are all on our radar. As you know, as physicians, there are patients at the top of the pyramid here that consume a disproportionate amount of healthcare resources. And so it is important, if you're someone who focuses, let's say, on patients with advanced heart failure, if you're focusing on patients that are getting towards end of life, that we start to think about what is the best means of managing these consumers of healthcare resources. Some of it is built upon around creating teams. Those teams might include care coordinators, nurses that are specifically trained, social workers that try to work with us as clinicians to prevent readmissions and to prevent avoidable visits to the emergency department. How will we do that? Obviously, you're all focusing in your own institutions on remote patient monitoring and other mechanisms, but this is so important. And cardiologists should be leaders in this area because you are so often involved in people who have these particular conditions. I would argue that secondarily only to oncologists in terms of the need to consider palliative care. So this is a slide that just says palliative care enhancement. We have, with our predictive analytics, started identifying patients that present for medical oncology appointments whose lifespan is frankly nearing its end. They may be only months away in our predictive algorithm setting from an end of life. And it is important that we as clinicians who are focused on treatment or focused on cure maintain a holistic view of what is important for our patients and to facilitate interactions with our expert colleagues in palliative care and geriatric medicine that will help us focus on what is the best way of managing goals of care and, frankly, quality of life for our patients. I want to switch a little bit now to AI and talk a little bit how we take our historical clinical data. I talked about how health systems have so much of that. Prototyping, development, and validation. In other words, taking that data and doing something with it, and then feeding it into a predictive engine. You can't do an AI talk without showing a slide like this. And the key thing is to talk about the environment in your organization. Again, cardiologists, you are data people. If your organization is not there yet, or even if your organization is on its journey, I think you should be part of the group that focuses on what it will take to use machine learning, artificial intelligence, although I prefer the term augmented intelligence, for helping our clinicians do their jobs more effectively, more efficiently, and frankly, with higher levels of quality and value. So on the left, we have a data production environment, all the various things that give us data. In the middle, where we have that yellowish box, we have a data interface, and the key is that data flow throughout the organization in a seamless fashion and in near real time. So as those data are accumulated, they can be put to the right of the screen towards our greenish box, where machine learning and the data science environment enable us to develop inference engines, enable us to know things that may be happening in the future of that particular patient. And then the bottom left of the slide, the key thing is communicating with staff. We have to communicate with staff, and the second piece of it, and the reason it is bidirectional, is there's also a clinician feedback box, and that is very important because the only way to make our algorithms better over time is to increase the assessment of what are the true positives of whatever we're trying to predict. And that occurs when our clinicians who are subject to the algorithms are able to give feedback, a thumbs up or a thumbs down. So Mount Sinai has developed several algorithms that are live and in production. We predict patients with severe protein count and malnutrition, those at high risk of falls, those at high risk of delirium. We're implementing now a new tool for assessing clinical deterioration and discharge planning, among others. We have probably about another 20 that are in various stages of development and implementation, but in the interest of time, I'll just move on and give you the concepts and the overriding principles such that we think about the situation, the goal, the action, and the result. And what we are trying to do with malnutrition is understand who is likely to have malnutrition and then take, as we do in all of these examples, a relatively rare group of people, in this case dietitians, and get them to the right patient at the right time. And then on the right side of the slide, to explain to them using techniques like random forest algorithms why we're making that prediction. That's very important, very different than radiology type data, where it's interpreting an image and pointing to a particular bit of pathology, let's say, or in cancer screening. So it's important that predictive engines work, and these are receiver operator characteristic curves, and it's also important that they work throughout a health system. We're very lucky, because when we looked at malnutrition, the same algorithm that was developed in the flagship hospital in Manhattan worked very well in other hospitals in our health system. And also that principle, again, that when we allow the clinicians to give feedback, things get better over time. So clinicians have to not just be part of creating algorithms, they have to be a living and breathing part of the implementation process and the process of iterative improvement. And this is, again, just the concept, again, that it is an environment, and I encourage you, I urge you to become part of the solution. I'll also note that a lot of our patients in health systems these days will have clinical deterioration on a regular patient floor. We only admit very sick people to the hospital these days. So we worked on a medical early warning system algorithm. We called it Muse++. I don't know why we came up with that name, but as we did a clinical trial, what we did was, again, using a random forest type model, tell our clinicians why we were sending nurses with low-level alerts to do more frequent vital signs, and the rapid response teams with higher-level alerts to intervene and to actually visit the patient at the bedside and make an assessment. And so this process was fascinating, and unfortunately, we had to cut the study short at 2,800 enrollees. We were powered to do 6,000, but in March 2020, of course, the pandemic occurred, and it prevented us from going further. But the key thing to look at from this slide was that the survival to discharge, or 30 days after admission, was approximately 39% better in the patients in the treatment units, and we had control units that were similar types of patients where we generated the algorithms but had no actions as a result. Now, will this hold up when we do larger cohorts, when we implement in other units? We don't know. But the point is, I want all of you to be involved in these types of efforts. I'll also note in the ad hoc outcomes that faster hospital discharge and getting patients to the ICU more effectively was very important. And I can't think of an area where cardiologists could be more helpful than in that world of critical care and of rapid response teams. So here's your call to action as we finish up. Cardiologists should remain in partnership to reduce acquisition costs of catheters, rhythm management devices, related supplies. That's the highest level of what you can do and very, very helpful. Sometimes we do this by limiting the number of vendors. That can be challenging. Some of us have relationships with multiple vendors. And of course, direct vendor negotiation. You're at the nexus of this. You can be very helpful and focus, of course, especially on cardiac rhythm management devices. And then ending up, as I began, and it's said in the middle, lead in creating quality and value-driven improvements, decreasing our failure to rescue with rapid response teams and enhanced nursing evaluations, timely referrals to palliative care for goals of care discussions. Many of our patients are reaching end of life, partnering and reducing expenses for supplies and labor by creating more efficient processes. And also in some of your hospitals, you care for enough people that you have limited means, and they're in the disproportionate share hospitals, and there is a 340B drug discount program. I encourage you to learn more about that and become an avid and active participant in facilitating 340B opportunity in ambulatory hospital care, especially for expensive drugs like the PCSK9 inhibitors. Thank you very much for listening to my presentation. And if there are any questions, I'm sure that Dr. Sharma and the other organizers will coalesce them. I look forward to being able to answer them in due course. Thank you and have a wonderful time at the conference.